Good morning, this is Retros Garcia, and I'm going to talk about the um, attention deficit hyperactivity disorder. So, first, I'm going to tackle about the overview of neurodevelopmental disorders. So, almost all disorders described in this book are developmental disorders in the sense that they change over time. Most disorders originate in childhood, although the full presentation of the problem may not manifest itself until much later. Disorders that show themselves early in life often persist as the person grows older, so the term childhood disorder may be misleading because the developmental disorders in this group are all believed to be neurologically based. DSM-5 categorizes them as neurodevelopmental disorders. So, in this chapter, we cover those disorders that are revealed in a clinically significant way during a child's developing years and are of concerns to families and educators. Remember, however, that these difficulties often persist through childhood and are typically lifelong problems, not problems unique to children. Again, a number of difficulties and indeed distinct disorders begin in childhood. In certain disorders, some children are fine except for difficulties with talking. Others have problems relating to their peers. Still, other children have a combination of conditions that significantly hinder their development. So, what is normal and what is abnormal? Recall that in Chapter 2, we described developmental psychopathology as the study of how disorders arise and how they change with time. Childhood is considered particularly important because the brain changes significantly for several years after birth. This is also when critical developments occur in social, emotional, cognitive, and other important competency areas. These changes mostly follow a pattern. The child develops one skill before acquiring the next, and subsequent skills often build upon one another. Although this pattern of changes only upon one another is only although this pattern of change is only one aspect of development, it is an important concept at this point because it implies that any disruption in the development of early skills will, by the very nature of this sequential process, disrupt the development of later skills. Like, for example, some researchers believe that people with autism spectrum disorder suffer from a disruption in early social development, which prevents them from developing important social relationships even with their parents. From a developmental perspective, the absence of early and meaningful social relationships have serious consequences. Children whose motivation to interact with others is disrupted may have a more difficult time learning to communicate. That is, they may not want to learn to speak, or if other people are not important to them. Researchers don't know whether a disruption in communication skills is a direct outcome of the disorder or byproduct of disrupted early social development. It may be important to identify children with attention deficit hyperactivity disorder, for example, because their problems with impulsivity may interfere with their ability to create and maintain friendships, an important developmental consideration. So, understanding this type of developmental relationship is important for several reasons. Knowing what processes are disrupted will help us understand the disorder better and may lead to more appropriate intervention strategies. Attention deficit hyperactivity disorder. Do you know people who flit from activity to activity, who start many tasks but seldom finish one, who have trouble concentrating, and who don't seem to pay attention when others speak? These people may have attention deficit hyperactivity disorder or ADHD. One of the most common reasons children are referred for mental health services in the United States. The Primary characteristics of such people include a pattern of inattention, such as being disorganized or forgetful about school or work-related tasks, or of hyperactivity and impulsivity. These deficits can significantly disrupt academic efforts as well as social relationships. Clinical description. People with this disorder have a great deal of difficulty sustaining their attention on a task or activity. As a result, their tasks are often unfinished and they often seem not to be listening when someone else is speaking. In addition to this, in addition to this serious disruption in attention, some people with ADHD display motor hyperactivity. Children with this disorder are often described as fidgety in school, unable to sit still for more than a few minutes. In addition, in addition to hyperactivity and problems sustaining attention, impulsivity, acting apparently without thinking, is a common complaint made about people with ADHD. For instance, during meetings at baseball practice, ADHD has two categories of symptoms according to DSM-5. First one is inattention. People may appear not to listen to others. They may lose necessary school assignments, books, or tools, and they may not pay enough attention to details, making careless mistakes. The second category of symptoms includes hyperactivity and impulsivity. Hyperactivity includes fidgeting, having trouble sitting for any length of time, and always being on the go. Impulsivity includes blurting out answers before questions have been completed and having trouble waiting turns. Either the first or the second and third hyperactivity and third set of symptoms must be present for someone to be diagnosed with ADHD. These different presentations are called subtypes, and they include the inactive subtype, inattentive subtype, what some may call ADD, noting the absence of hyperactivity, although this is not an official diagnosed level, and the hyperactive impulsive subtype. Other individuals meet criteria for both inattention and hyperactivity impulsivity, and these individuals are labeled with a combined subtype. Inattention, hyperactivity, and impulsivity often cause other problems that appear secondary to ADHD. Academic performance often suffers, especially as the child progresses in school. The cause of this poor performance is not known. It could be a result of inattention and impulsivity, and in some children, this can be made worse by factors such as concurrent learning disabilities. Genetic research on both ADHD and learning disabilities suggests that they may share a common biological cause. Children with ADHD are likely to be unpopular and rejected by their peers. These too may be the result of genetic factors as well as environmental influences such as a hostile home environment and environment interactions. For example, some research shows that having a specific genotype and psychosocial distress can predict ADHD in children. Statistics. An important analysis of prevalence of ADHD suggests that the disorder is found in about 5.2% of child populations across all regions of the world. This finding of comparable rates of ADHD worldwide is important because debates continue to rage about the validity of ADHD as a real disorder. Some people believe that children who are just normally active and are misdiagnosed with ADHD. Previously, geographic differences were noted in the number of people diagnosed with this disorder. Children were more likely to receive the label of ADHD in the United States than anywhere else. For example, an analysis of data from surveying parents over the phone suggests that 11% of children in the United States aged 4 to 7 15 were labeled with ADHD between 2011 and 2012. This higher number may suggest that it is being overdiagnosed in the United States. Based on these different rates of diagnosis, some have argued that ADHD in children is simply a cultural construct, meaning that the behavior of these children is typical from a developmental perspective, and it is Western society's intolerance due to the loss of extended family support, pressure to succeed academically, and busy family life that causes labeling ADHD as a disorder. The best data suggests, however, that from 5% to 7% of the worldwide population of children currently meet the criteria for ADHD, and 3% to 5% have symptoms that significantly interfere with their quality of life. Boys are 2 to 3 times more likely to be diagnosed with ADHD than girls, and this discrepancy increases for children being seen in clinics. The reason for this gender difference is largely unknown. It may be that adults are more tolerant of hyperactivity among girls, who tend to be less active than boys with ADHD. Boys tend to be more aggressive, which will more likely result in attention by mental health professionals. Girls with ADHD, on the other hand, tend to display more behaviors referred to as internalizing, specifically anxiety and depression. The higher prevalence of boys identified as having ADHD has led some to question whether the DSM-5 diagnostic criteria for this disorder are applicable to girls. Most research over the past several decades has used young boys as participants. This focus on boys may have been the result of their active and disruptive behavior, which caused concern among families and school personnel, and therefore prompted research into the nature, causes, and treatment of these problems. More boys displayed these behaviors, which made it easier to find participants to study. This concern is being raised by some psychologists, including Kathleen Nadeau, a clinical psychologist who specializes in girls with ADHD, who argues that more research is needed on ADHD in girls. Girls experience significant struggles that are often overlooked because their ADHD symptoms bear little resemblance to those boys. She says that girls with ADHD were neglected because their symptoms differ dramatically from boys' symptoms, although to date there is little firm evidence for these differences. Just as researchers are now exploring ADHD among adults, in addition to children, more research is now addressing the relative lack of research on girls and women. This expansion of research across age and gender bodes well for a fuller understanding of the disorder. Children with ADHD are first identified as different from their peers around age 3 or 4. Their parents describe them as active, mischievous, slow to toilet train, and oppositional. The symptoms of inattention, impulsivity, and hyperactivity become increasingly obvious during the school years. Despite the perception that children grow out of ADHD, their problems usually continue. It is estimated that about half of the children with ADHD have ongoing difficulties through childhood. Over the time, children with ADHD seem to be less impulsive, although inattention persists. During adolescence, the impulsivity manifests itself in different areas. For example, teens with ADHD are at greater risk for pregnancy and contracting sexually transmitted infections. They are also more likely to have driving difficulties such as crashes, to be cited for speeding, and to have their license suspended. So, the question is, what happens to children and adolescents with ADHD as they become adults? Rachel Klein and their colleagues followed up on more than 200 boys with these disorders and reported on their status 33 years later. When compared with the group without ADHD. The majority of these men, 84%, were employed but in jobs with significantly lower positions than the comparison group. They also had 2.5 fewer years of education and were much less likely to hold higher degrees. These men were also more likely to be divorced and to have substance use problems, and antisocial personality. In addition, the effects of their tendency to be impulsive may account for their increased risk of displaying risky driving, having a sexually transmitted disease, increased chance of having a head injury, and more emergency department admissions. In short, although the manifestations of ADHD change as people grow older, many of their problems persist. Causes. Researchers have known for some time that ADHD is more common in families in which one person has the disorder. For example, the relatives of children with ADHD have been found to be more likely to have ADHD themselves than would be expected in the general population. It is important to note that these families display an increase in psychopathology in general, including conduct disorder, mood disorders, anxiety disorders, and substance use. This research and the comorbidity of the children themselves suggest that some shared genetic deficits may contribute to the problems experienced by individuals with these disorders. ADHD is considered to be highly influenced by genetics. Environmental influences play a relatively small role in the cause of the disorder when compared with many other disorders we discuss in this book. As with other disorders, researchers are finding that multiple genes are responsible for ADHD. In its simplest form, we tend to think of genetic problems in terms of having genes turned off, not making proteins, when they should be turned on, and vice versa. Research on ADHD is finding that in many cases, however, mutations occur that either create extra copies of a gene on one chromosome or result in the deletion of genes. For several decades, ADHD has been thought to involve brain damage, and this notion is reflected in the previous use of labels such as minimal brain damage or minimal brain dysfunction. The rapid advances in scanning technology now permit us to see just how the brain may be involved in this disorder. A great deal of research on the structure and the function of the brain for children with this disorder has been conducted over the past few years. In general, researchers now know that the overall volume of the brain in those with this disorder is slightly smaller, 3 to 4%, than in children without this disorder. A number of areas in the brains of those with ADHD appear affected, especially those involved in self-organizational activities. These changes seem less pronounced in persons who receive medication. In fact, a number of studies now point to a growth-enhancing effect of stimulant medication, suggesting that brain development progresses in a more typical fashion in children receiving medication for ADHD versus those who do not. Treatment of ADHD. Treatment for ADHD has proceeded on two fronts: psychosocial and biological interventions. Psychosocial intervention recommend various behavioral interventions to help these children at home and in school. In general, the program sets such goals as increasing the amount of time the children remain seated, the number of math papers completed, or appropriate play with peers. Reinforcement programs reward the child for improvements and, at times, punish misbehavior with loss of rewards. Other parent education programs teach families how to respond constructively to their child's behaviors and how to structure the child's day to prevent difficulties. Social skills training for these children, which includes teaching them how to interact appropriately with their peers, also seem to be an important treatment component. For adults with ADHD, cognitive behavioral intervention to reduce distractibility and improve organizational skills appears quite helpful. Most clinicians typically recommend a combination of approaches designed to individualize treatments for those with ADHD, targeting both short-term management issues and long-term concerns. Biological interventions. The first type of medication used for children with ADHD were stimulants. Since the use of stimulant medication for children with ADHD was first described, hundreds of studies have documented the effectiveness of this kind of medication, reducing the core symptoms, hyperactivity, impulsiveness of the disorder. It is estimated that 3.5 of the children living in the United States are being treated with medication for symptoms of ADHD. Drugs such as methylphenidate and several non-stimulant medications such as atomoxetine, guanfacine, and clonidine have proved helpful in reducing the core symptoms of hyperactivity and impulsivity and in improving concentration of tasks. To determine whether or not a combined approach to treatment is the most effective, a large-scale study initiated by the National Institute of Mental Health was conducted by six teams of researchers labeled the multimodal treatment of attention deficit hyperactivity disorder. This 14-month of study included 579 children who were randomly assigned to one of four groups. One group of the children received routine care without medication or specific behavioral interventions. The three treatment groups consisted of medication management, intensive behavioral treatment, and the combination of the two treatments. Initial reports from the study suggested that the combination of behavioral treatments and medication alone were superior to behavioral treatment alone and community intervention for ADHD symptoms. For problems that went beyond the specific symptoms of ADHD, such as social skills, academics, parent-child relations, positional behavior, and anxiety or depression, results suggested slight advantages of combination over single treatments. Some controversy surrounds the interpretation of these findings, especially whether or not the combination of behavioral and medical treatments is superior to medication alone. One of the concerns surrounding the study was that although medication continued to be dispensed, behavioral treatment was faded over time, which may account for the observed differences. Practically, if there is no difference between these two treatments, most parents and therapists would opt for simply providing medication for these children because of its ease of use and lower time commitment. Behavioral intervention have the added benefit, however, of improving aspects of the child and family that are not directly affected by medication. The interpretations of the data from this large-scale study continue, and more research likely will be needed to clarify the combined and separate effects of these two approaches for treatment. Despite these advances, however, children with ADHD continue to pose a considerable challenge to their families and to the educational system. Diagnostic criteria for attention deficit or hyperactivity disorder. A persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development is characterized by number 1, attention. 6 or more of the following symptoms have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. Note, the symptoms are not solely a manifestation of oppositional behavior. Defiance, hostility, or failure to understand tasks or instructions. For older adolescents and adults aged 17 and older, at least 5 symptoms are required. First symptom is often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or during other activities. Often difficulty sustaining attention in tasks or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, and duties in the workplace. Often has difficulty organizing tasks and activities. Often avoids, dislikes, or is reluctant to engage in tasks that required sustained mental effort. Often loses things necessary for tasks or activities. Is often easily distracted by extraneous stimuli. Is often forgetful in daily activities. Second, hyperactivity and impulsivity. Often fidgets with or taps hands or feet or squirms in seat. Often leaves seat in situations when remaining seated is expected. Often runs about or climbs in situations where it is inappropriate. Often unavailable to play or engage in leisure activities quietly. Is often on the go, acting as if driven by a motor. Often talks excessively. Often blurts out an answer before a question has been completed. Often has difficulty waiting his or her turn. Often interrupts or intrudes on others. Letter B. Several inattentive or hyperactivity impulsive symptoms were present prior to age 12. C. Several inattentive or hyperactivity impulsive symptoms are present in 2 or more settings. Letter D. There is clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And letter E. The symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder. Combined presentation if both criterion A1 inattention and criterion A2 hyperactivity impulsivity are met for the past 6 months. Predominantly inattentive presentation if criteria A1 is met by criteria A2 is not met for the past 6 months. Predominantly hyperactive impulsive presentation if criteria A2 is met and criteria A1 is not met for the past 6 months. That's all. Thank you.